Hello, my name is Kathleen Martin Ginis, and I'm a professor at the University of British Columbia. I work at UBC's Okanagan campus, which is situated on the traditional, ancestral, and unceded territory of the Syilx Okanagan Nation. And here are my disclosures. The content of this presentation is derived primarily from our Lancet Physical Activity Series paper, and I want to acknowledge my international team of co-authors and the research assistants who supported us. Our paper focuses on disability, which is not merely defined by what a person's body can or cannot do. Rather, disability is a complex interaction between characteristics of a person's body and society. People become disabled when they encounter physical, social, or attitudinal barriers that impede their ability to fully participate in society. It's estimated that roughly 1.5 billion people worldwide live with some form of disability, and this reflects approximately 6% of children and 15% of adults. Now, these populations are terribly underserved and understudied. Compared to the general population, people with disabilities are at greater risk of developing chronic conditions such as diabetes and cardiovascular disease. They face greater barriers to accessing health care and have higher rates of health compromising behaviors such as smoking and poor nutrition. And they're less likely to receive health promotion and disease prevention services. And while people with disabilities comprise about 15% of the world's population, over the past 20 years, just 0.3% of papers published in leading medical journals were about the health of people living with disabilities, and just a handful of these were specifically about physical activity. In this presentation, I will draw on our Lancet paper to provide an overview of the health benefits and activity levels of disability populations, to discuss factors associated with physical activity, and to look at the effectiveness of interventions to increase physical activity. With these, I'll identify some research gaps, challenges, and priorities, and finish with some calls to action. Starting with the benefits. For our Lancet paper, we conducted a meta-synthesis of 36 meta-analyses that looked at the outcomes of physical activity interventions in people with disabilities. Overall, there was consistent evidence that physical activity leads to improvements in cardiorespiratory and musculoskeletal fitness, psychosocial well-being, and cognitive function. For cardiometabolic outcomes, the evidence was not as consistent. However, overall, there were still positive effects. Now, these results are encouraging, but they are based on a limited number of outcomes. Unlike in the general population, in disability populations, there have been virtually no studies of the effects of physical activity on the risk for all-cause mortality or the risk for specific chronic conditions such as cardiovascular disease or diabetes. Few of the studies have been adequately powered, but it's important to note that this is a reflection that scientists are recruiting people with conditions that have relatively low population base rates. Disability researchers just don't have the same big pool of study participants to draw from that are available to general population physical activity scientists. Of note, most of the studies in the meta-analyses prescribed physical activity of less than 150 minutes per week. On the one hand, this might explain why there were so many non-significant effects for the cardiometabolic outcomes. But on the other hand, the consistent significant effects for the other outcome categories show that people with disabilities can achieve substantial fitness and health benefits from physical activity prescribed below the 150-minute per week guideline, and that inactive people can achieve big benefits from small increases in physical activity. And this finding is important to keep in mind, given that the World Health Organization has released physical activity guidelines for people with disabilities that are based on research evidence derived from the general population, not disability populations. The WHO's disability guidelines are identical to what's recommended for the general population. That is 150 to 300 minutes per week of MVPA for adults. In contrast, disability-specific guidelines have also been developed for some groups, such as people with spinal cord injuries or multiple sclerosis, based on research evidence derived specifically from those populations. These are impairment groups who do not necessarily have the same physiological response to exercise as the general population, And so it may not make sense for these groups to follow generic population physical activity guidelines. The disability research underpinning these guidelines shows improvements can be achieved at much lower, more realistic levels of activity. So for instance, the SCI exercise guidelines recommends just 20 minutes of MVPA twice per week and strength training twice per week for cardiorespiratory and muscular fitness benefits. So how active are people with disabilities? For our Lancet paper, we pulled together all of the population studies we could find on physical activity rates of people with disabilities. Overall, our synthesis showed that people with disabilities are 16 to 62% less likely to meet physical activity guidelines than people without disabilities. And you might be wondering why that estimate has such a huge range. Well, unlike in the general population, for whom we have reams of national and international population level physical activity data, for disability populations, these 5 lines of data are pretty much all we have. That's because having a disability is typically an exclusion criteria for participating in population level surveillance systems. Or disability is not measured in these systems, so we cannot parse out data for those with and without disabilities. And for the data sets we do have, different definitions of disability and different measures of physical activity have been used, making for inconsistent estimates. Furthermore, the physical activity measures that are well used in the general population have questionable validity in certain impairment groups. For instance, pedometers and accelerometers may not be appropriate for people who use mobility devices such as wheelchairs, canes, and crutches. And self-report measures may lack validity for people with cognitive or intellectual impairments. Because of these limitations, we have almost no population level data from high-income countries and no data from low or middle-income countries. Now, I recognize that participation in international disability sporting events is not at all the same as grassroots or daily physical activity participation. But I think we can glean some insight on national attitudes and social norms toward disability and physical activity by looking at countries' participation in these events. In our Lancet paper, we looked at the total number of athletes that countries sent to the Paralympics, Special Olympics, and Deaf Olympics between 2016 and 2019. This map shows the tremendous disparities in participation between high and low and middle income countries. So while participation rates for people with disabilities are 16 to 62% less in high income countries compared to the general population, the picture is probably even more bleak in low or middle income countries. And these low physical activity participation rates are a reflection of the tremendous barriers experienced by people with disabilities. In 2 meta-reviews of nearly 20 review papers on this topic, we identified 228 barriers and facilitators to physical activity. We categorized these into themes and situated them in a social ecological model. From this analysis, it's clear that people with disabilities face extensive barriers to physical activity at all levels of the social ecological model and across both the healthcare and recreation sectors. An important caveat is that we have almost no data from low or middle income countries where I suspect there are additional, perhaps more complex barriers. And we have very few studies testing which factors are the strongest determinants of physical activity, and here there is a need for theory-based research. Overall, the number and range of barriers attest to the need for multi-level approaches to intervention design and research. What do we know so far about the effectiveness of community-based physical activity interventions that have attempted to increase physical activity by targeting these barriers? For our Lancet paper, we undertook a meta-review of meta-analyses testing the effects of physical activity enhancing interventions in children, youth, and adults with disabilities. We found 9 meta-analyses in total, 3 of which included studies with children. All of these interventions targeted factors at the interpersonal or intrapersonal levels, such as physical function, motivation, self-efficacy, or social support. 7 meta-analyses involved people with physical disabilities. Overall, these meta-analyses supported the effectiveness of the interventions with a median effect size in the medium to large range of 0.64. We found only 2 meta-analyses of people with intellectual disabilities, and these effect sizes were not as strong and were in the small to medium range. Overall, the research suggests that interventions targeting intrapersonal and interpersonal level factors can increase physical activity in people with disabilities. However, once again, we don't have any studies from low or middle income countries. And the studies that have been conducted have focused on a narrow range of disability populations. People with disability are a tremendously heterogeneous group, not just in terms of age, but also the types of impairments, whether the disability is congenital or acquired, chronic or intermittent, and so on. So it's very difficult to generalize from the limited research. Also, we've seen very few studies of institutional, community, or policy level interventions. But on the plus side, we have seen that the largest effects are for theory-based interventions that use behavior change techniques. Which behavior change techniques are the most effective? Dr. Jasmine Ma and I published a meta-analysis of 24 randomized controlled trials of physical activity interventions for people with disabilities. Over 30 different behavior change techniques were used in these RCTs. We looked at the effects of the interventions on physical activity behavior for studies that used versus did not use a particular behavior change technique. We found that interventions that use self-monitoring, gave behavioral feedback, provided instructions on behavior, and used problem solving had greater increases in physical activity than studies that did not implement these techniques. Interestingly, studies where participants' behavior was monitored by others, but they didn't receive any behavioral feedback, these studies produced significantly smaller changes in behavior than studies that did not use that technique. Given the current state of the evidence, there are a few key things that scientists and interventions can do to better intervene for these populations. First, we need greater efforts to design, implement, and evaluate multi-level interventions to alleviate systemic barriers to physical activity. We need to shift the research focus from merely describing barriers and facilitators to identifying and intervening on the strongest determinants. And we need to collaborate with end users to develop tailored evidence and theory-based interventions that meet users' needs. And I believe we also need to have a shift in perspective. We need to stop thinking of intervening and removing barriers to physical activity for people with disabilities as a nice thing to do. Rather, physical activity for people with disabilities is a human rights issue. As shown on the left, various international policies and treaties recognize the rights of people with disabilities to participate in physical activity on an equal basis with others, but much more work needs to be done to put these policies into practice. Globally, we need to adequately resource action plans empowering people with disabilities to participate in physical activity. We need to challenge and prevent ableism, which is favoritism and idealism associated with able-bodiedness. And people with disabilities must be equal partners with researchers and policymakers to create new knowledge and policies. Nothing about us without us is a slogan used within disability communities to communicate the idea that no policy should be decided on without the full and direct participation of the people who it will influence, that is, people with disabilities. Integrated knowledge translation is a knowledge co-production approach that aligns with the idea of nothing about us without us. This approach aims to ensure research is developed and translated into practice by engaging research users as partners throughout the entire research process, all the way from applying for the grant through to the dissemination of the findings. Dr. Heather Gainforth has worked with people with disabilities and disability organizations to develop a set of 8 integrated knowledge translation guiding principles that can be used by researchers to meaningfully engage people with disabilities throughout the research process, and I urge you to check them out. If there's one thing I want you to take away from my presentation today, I want it to be that physical activity for people with disabilities is an issue that demands better evidence, surveillance, practice, respect, and value. I leave you with 3 global calls to action. First, accurate population level physical activity estimates are the cornerstone of international physical activity action plans. We need coordinated efforts worldwide to end exclusionary scientific practices and to collect population-level physical activity and health data from children, youth, and adults with disabilities. Second, there needs to be adequate resources and enforcement devoted to policies and action plans to advance fundamental rights of people with disabilities to fully participate in physical activity. And third, we need to ensure that people with disabilities are meaningfully engaged as equal partners in the development of research and policy. I thank you very much for your attention, and here is my contact information.